So as I said today, I will be talking about the perils and the management of Turner syndrome. I have no disclosures. My presentation goals is for you to be able to identify common challenges in imaging and management of these patients, to be able to determine appropriate imaging modalities, to be able to identify perils in the management of Turner syndrome. But the most important message that I want to give to you today is that people that live with Turner syndrome come to harm at significantly smaller sizes in the diameter of the aortas when compared to non-Turner syndrome genetically triggered aortopathy. As we all know, people that do imaging, in Turner syndrome imaging like the one that I'm presenting here is as good as it gets. Even if I manage to get the video to play, it doesn't get better than this. A study showed that up to 30% of patients get missed on having a diagnosis of bicuspid aortic valve with the use of echo. So decision-making in image modality, I'm going to try to do this briefly, but of course we have transthoracic echo. This should be done in every patient at initial diagnosis. In the pediatric population, it is very good for bicuspid aortic valve and ruling out any other form of congenital heart disease, and of course in the long-term surveillance of their aortic dilation. Cardiac MR can be considered a diagnosis, particularly in the adult patient, but one has to remember that this is typically in pediatrics at the age of around 13 when they don't need sedation. It should be done in preparation or anticipation of pregnancy, and as you all know, in adult patients it's a much better modality to diagnose bicuspid aortic valve and congenital heart disease in adult patients. And briefly, gated CT, the single point is that it's a more sensitive test in measurements of progressive enlargement of the ascending aorta. So in non-Turner's genetic aortopathy syndromes, absolute diameter is commonly used in clinical decision making. In Turner syndrome, we need to normalize, and that's what I'll be speaking to you about in the next few slides. First and foremost, it is very important for providers taking care of patients with Turner syndrome to be familiar with the current international guidelines of clinical care. Much of what I'll be speaking to you today is based on the AHA scientific statement, which is the most recent one in cardiovascular health in patients with Turner syndrome. So a little bit of background. We know that patients with Turner syndrome nearly always have a generalized aortopathy that leads to increased morbidity and mortality. Having Turner syndrome itself without any other form of heart disease poses a risk for aortic dissection, and conditions that reduce their lifespan have been described. In rare but fatal cases of dissection, they tend to occur in approximately 40 per 100,000 person years. When we compare this to the general population, in which this occurs in approximately 6 per 100,000 person years, significantly high in Turners. And again, the important point today is that aortic dissection occurs in smaller aortic diameters in the Turner syndrome population. Just a quick reminder, the aortic size index, which is ascending aorta in centimeters divided by the patient's body surface area. This was described by Drs. Matura and Bondi, who proposed that this was a very sensitive and specific index. And this was further clarified in the AHA's scientific statement. We looked carefully at the aortic size index in Turner syndrome, comparing it to age, and found that it's both a sensitive and a specific marker for the risk of aortic dissection. In this graph, you can see the aortic size index on the y-axis, and that's in centimeters per meter squared. And you can see that that's compared with age in years in the x-axis. Please note that there's a red dotted line there, and it's marking the 2.5 aortic size index, and it divides the group into higher than 2.5 and lower than 2.5. So we looked at 481 patients that received the echoes and did not have aortic dissection. Those are the black dots on that graph. In the 15-year mark is this red line that's vertical, and this 15 mark is at 15 years, and this is a very key number in Turner syndrome. Sorry about that. So we compared Turner syndrome patients reported in the literature in which echo was done prior to aortic dissection. Those are the blue triangles in the upper quadrant. As you can see here, nearly all the patients with Turner syndrome that were older than 15 years of age and had an ASI of greater than 2.5 had an aortic dissection, making this this index very sensitive. On the other hand, in patients that again are older than 15 years of age with an ASI lower than 2.5, they had no dissection, and therefore this is also a very specific marker of aortic dissection. On the other hand, you can see that patients that were younger than 15 years of age but had an ASI greater than 2.5 basically had no dissection. Of all the patients that of the aortic dissection, not one happened under the age of 15 years. But if you notice here, under the age of 15, there are approximately 22 patients in that red square that have an ASI greater than 2.5. So more likely what's happening there, sorry, this should be this arrow, is that their bodies are growing into the size of their aortas. Once the 15-year mark passes, this relationship stabilizes. This table was extracted from Dr. Davis's paper. This group looked at all patients with genetically triggered aortopathies, and no one in the study had Turner syndrome. They stratified this group into low, which is the white on the left lower corner, with a risk of less than 1% per year, moderate risk in the light gray, 8 to 20% risk per year, and high risk in the dark gray, greater than 20%. As you can see here, the columns are all aortic size in centimeters, and it's an absolute value. And the rows are BSA. All the numbers within the tables are aortic size index. In patients that don't have Turner syndrome, who had an ASI of 2.5 or less, they had only about 1% risk of aortic dissection. This is quite different from what I just showed before, that in Turner syndrome population, if you had an ASI of 2.5, you have an aortic dissection risk of greater than 80%. The difference between them is that in non-Turner's genetic aortopathy, with an ASI of 2.5, you have a very low risk. And in patients that have a in Turner's genetic aortopathy, with an ASI of 2.5, if you're older than 15, your risk is extremely high, greater than 80%. This is a graph showing the accepted management decisions for genetically triggered aortopathies without Turner syndrome, and this is using absolute diameters. This is the accepted management approach, because if we normalize non-Turner syndrome genetic aortopathies, we would fail to treat patients with significant risk. As pediatric cardiologists, we manage genetically small children by normalizing to their body size. We use the short stature references. This is the Turner syndrome individuals that did not have obvious aortic heart disease. We used the standard C-scored method that is commonly used in pediatrics clinical care, and we compared aortic diameters to an age-matched Turner syndrome healthy population. We calculated mean and standard deviations, and as you all know here, each standard deviation accounts for one C-score. We created a Turner syndrome specific C-score calculator that you have available online. All the authors in this paper, with the exception of one, are sitting today with us in the room. In this study, they looked at 246 individuals less than 30 years of age with Turner syndrome. And what they did is they compared Turner syndrome specific C-scores with the Boston C-scores. This is the non-genetically affected normal stature young people. And they found that Turner syndrome specific C-scores were significantly lower, and they concluded that using the Boston C-scores in Turner syndrome patients would lead to inappropriate restrictions on healthy physical activities, unneeded medications, and unneeded operations. The AHA scientific statement provides clear suggestions on the management of patients with Turner's. In Turner syndrome, individuals that are younger than 15 make clinical decisions based on Turner syndrome specific C-scores. While if you're older than 15, you should make decisions based on the aortic size index. It's important always to rule out risk factors, which include additional congenital heart disease or hypertension. For Turner syndrome individuals that are younger than 15 years of age, after you do your initial diagnostic workup, you rule out congenital heart disease or hypertension, you should make your decision based on Turner syndrome specific C-scores. To give you an example, if you focus on the right side of your screen, this is a patient that has, let's say a patient that had a history of repaired coarctation and is hypertensive, and in clinic you see him with a Turner syndrome C-score of 3. In this patient, you should consider doing more frequent visits in between 6 months and 12 months, or even more frequent depending on each case. And you start considering medical therapy with beta blockers or angiotensin receptor blockers. Similarly, in the group of patients with Turner's that are older than 15 years of age, you should base decisions on aortic size index. Again, briefly another example, a patient with a bicuspid valve and hypertension who has an ASI of greater than 2.3, you should see this patient again in clinic more frequently and start thinking of regular medical management. Finally, one should consider operative management in Turner's aortopathy in the same different groups. If you're younger than 15 years of age, one should consider surgery if you have a Turner specific C-score of greater than 4. And if you're older than 15 years, older or equal than 15 years of age, you should use the aortic size index, and the number should be greater than 2.5. And that's it. So I thank you for your attention.
Hopefully we've got a few minutes. My calculation, I think we have